Hello, good morning. My name's Chris Bates. I'm the Research and Analytics Director at TPP, and we are an electronic health records and clinical systems provider based here in the UK. I'm going to talk to you about the OpenSAFELY platform. This is a platform that myself and Ben Goldacre have been talking to the Open Data Saves Lives team on and off for the last 18 months. So I'm here to give you a bit of an update, but also a little bit of a history about the platform, the principles, some of the science we've been doing, and some of the policy implications that have come from the work. So firstly, and apologies for those of you who know some of this, but a little bit of history. So if we roll back to March 2020, when the pandemic was really taking hold here in the UK, we were asked to, in short, a question, which was, in the context of this global emergency, could we jointly create a highly secure, safe platform for EHR research on a massive scale across millions and millions of records, and could we do it very quickly? And this was a collaborative approach between TPP, software vendors, and also with the University of Oxford and the EBM Data Lab, the London School of Hygiene and Tropical Medicine, and working on behalf of the NHS, and trying to answer questions that came from the NHS were really important about the pandemic, but also were coming from the Chief Medical Officer and the Chief Scientific Advisor in the government. And the answer was yes. And in a 6-week period, we built the OpenSAFELY platform from a standing start to the point where we could do powerful analyses. So OpenSAFELY is a secure, transparent, open source software platform for the analysis of EHR data. It's deployed on top of electronic health record databases to create a trusted research environment. But one of the unique things is that it's built in the secure data center where the electronic health records provided by the vendor, in this case TPP, where those records are stored. So that's NHS accredited data centers. So instead of the data moving location and extracts going out to research teams, it stays where it is and all analysis takes place in situ. It means that the engineers and the epidemiologists inside the universities and inside the NHS work very closely with the EHR software developers who know the data extremely well, creating a powerful team with a lot of complementary skills, but different engineering and analytics skills with very little redundancy, which allowed us to work very, very quickly. And on the slide here, you can see another of the key characteristics was to approach with different levels of data access. So we wanted to make sure that the research teams could access the full power of event level, high dimensional electronic health record data, but we wanted to mitigate against some of the risks that data can cause. So all data, and this is a standard approach many of us will know, is pseudonymized when we're wanting to provide research level extracts. So all identifiers, mobile phone numbers, names, addresses are all dropped. Any linkable identifiers, such as the NHS number, are hashed, so we can do that. So you have a database where most of those identifiers have gone, well, all of them have gone. However, that still leaves you with a problem, and the problem is that a small combination of healthcare data items can identify people pretty quickly. If you know someone very well and you happen to be working with raw de-identified data like that, you may be able to infer who that person is. If it's someone whose life is played out in the public, that's very much the same. So, for example, Ross Anderson in his Security Engineering Bible gives the fairly famous example that if you were to query all males born in 1953 on an EHR database, and look for people who were treated for atrial fibrillation on October the 19th, 2003, then you've probably found Tony Blair, because it's a small combination of items that identify that a small group of people, and all of that was published in the papers and still available online today. So it's important that we mitigate against that. And to do that, that means that the actual research teams only ever work with anonymized aggregate data. They can run queries on that high dimensional powerful data, but they can only they don't ever see any raw patient data when they're doing this analysis. They can't manipulate that, they can't see it. They work at arm's length from that using the OpenSafer services that have been developed. So what's some of the core principles around OpenSAFELY? Well, if you quickly here on screen, there's a pseudonymization and access controls that I've mentioned, some core designs around privacy and transparency, a very collaborative approach that we've taken. Lots of transparency and public logging. I'll give you examples of this in a minute. And we're trying to contribute to best practice around open science, open working and open sharing. So we are working in that open environment. And of course, this is the Open Data Saves Lives showcase and Unconference. This is about as unopened data as you could possibly have. This is not, electronic health record data like this about people's medical conditions is not something where you can work with it in the open, but you can have open science principles to analyze that data and allow us to do things in a more collaborative way, and in a way that encourages trust as well. So what are some of the core features of OpenSAFELY that are there that sort of abide to these principles? Well, firstly, all the data management tools that are used that researchers use also produce research-ready data sets of simulated, randomly generated dummy data. So that every researcher has a full offline fictitious development environment to build their code. And only when that code, the analytic code, does the job it's supposed to do, when it's been checked by people, can it actually execute against live code. For every analysis, only the really minimal disclosive summary data is released outside of the secure environment. So that may be summary tables and figures, and only after strict disclosure checks have taken place. So there's no data going out, there's nothing that could disclose any confidential information is actually released from that environment at all. We've taken a very collaborative approach. I've mentioned NHS England and NHSX, but of course we're working closely with other groups, certainly other academic groups around the country, to try and maximise the use of the platform for the best science. So, for example, we're now working closely with the ISARIC group, and we're working with the HDR UK National Core Studies groups, very closely with the Office of National Statistics team. That's been a good collaboration over the last 18 months, and also with the FOSP group, who are doing lots of interesting work into long COVID. What else? Well, all public code that's all code that's ever executed against OpenSAFELY is made available to the public. All jobs that are running are made available to the public. Any project that's ever been started is also visible online. And we're also trying to contribute to best practice around science, as I've said. Because of that, the analytic code needs to be written up front against dummy data. It contributes very well to a clean study design, where all analyses are defined up front to try and promote best science. So if we look into the implications of some of that, well, what does that mean? Well, if you want to run the OpenSAFELY platform against your own electronic health records database, then all of the code is publicly available. You can go to the OpenSAFELY core GitHub repo here, and you can, with some technical skills, make sure that you can take all that code and run it against your own trusted research environment, building on the OpenSafer services and the tooling that's been developed over the last 18 months. As I said, if you want to see what's going on in OpenSAFELY, that's all available. So this is the day I took the screenshot. Here, you can see at jobs.opensafely.org exactly what's running. So you can see there's a COVID vaccine effectiveness study, there's a breakthrough infection study running for people who've been vaccinated, and there's some surgical outcomes data analysis that's running as well for poor surgical outcomes for people who may have had COVID. So, and you can drill into those. So if you wanted to see who was running that job, the code it was executing against the repo, all of those details are available, and they're all publicly logged and audited forever. So you can see exactly what's happened over time. Why is that important? Well, I think we're all aware how important public trust is when you're doing analyses at this scale. We've seen numerous times in numerous countries when you don't have that trust, you can't unlock the power of electronic health record data. Because people are suspicious of the analyses that are running, and they don't think they can see what's happening with their data. So if you look at very recently some citizen juries, 3 citizen juries that were run by the National Institute for Health Research into data sharing in the pandemic, looking at different data sharing approaches and programs, and how supportive citizen juries were of those approaches, and how supportive they were of those programs continuing post-COVID. And if you look just underneath me here, you can see that for OpenSAFELY, that data sharing method, 77% of people were very much in support, 23% broadly supportive, and nobody was less supportive than that. And why was that? Well, if you look at the icon, the feeling was it was supported because it was considered to be more transparent than other initiatives. People knew what was happening with their data. They knew they could see what it was being used for. And that does bring people's trust into why the data is important. So going on to some of the science. Well, our initial question, the first thing we were charged with doing was to come up with a descriptive analysis of the factors that were associated with poor COVID-19 outcomes. There's a clinical factors and demographic factors, and we did that this was published back in July 2020 in Nature, and gave a really broad description across 17 million records. Like I said, this is all at massive scale. So the biggest COVID-19 risk study that's taken place, I believe, still so far in the world. We were able to do that very quickly and publish that. Since then, there's about 30 different publications and preprints that are available, and if you go to the OpenSAFELY website, you can see all these publications. And there's a suite here that were published in the Lancet over the last 12 months. And the important thing really was we're trying to answer important questions. So it was questions that mattered to people, mattered about clinical decisions and about people's lives. So, for example, was it safe to take ibuprofen during the pandemic? Anecdotally, early on, there was thoughts that it wasn't. Well, it is safe to take ibuprofen. We were able to prove that. Should people living with asthma or COPD continue to take their inhalers? Absolutely, they should. It's safe to do that. Does hydroxychloroquine, quite famously, does that work to prevent serious illness for people who've contracted COVID-19 in the community? No, it doesn't. So you're able to provide the evidence base for really important questions, and we've continued to do that. As the vaccination campaign started to roll out, we were able to produce rapid reports to government around vaccine uptake. Importantly, being able to break that down into different subgroups. So ethnic subgroups, deprivation subgroups, subgroups of people living with different conditions. So this is something that was picked up by The Guardian in January, where we were able to show a massive disparity between black people over 80 who were getting the COVID jab and white people over 80 who were getting the COVID jab. And it was half as likely that a black person had that jab as a white person. So a huge disparity. And of course, that has implications to policy and to interventions to try and close that gap. Again, in The Guardian, and sticking with health inequalities, I mean, a quite shocking statistic, really, that we were able to show that people living with learning disabilities in England have 8 times the COVID death rate of people living without those conditions. Obviously, that's a massive inequality, that we were able to show that exists. What can be done about it? How, again, do we close that gap? Moving forward, of course, now there's lots of concern around long COVID and people who have contracted COVID and then living for a very long time with some significant symptoms. What we've been able to show is that actually, compared to the survey estimates of who's got the number of people that are living with this condition and what's making it back onto medical records, well, actually, there's a huge disparity there. So it's not been recorded. And if we're going to do important analyses in OpenSAFELY and other databases, similarly in HDR UK working to COVID-19, we need to make sure we can identify people who are living with long COVID in an accurate way, in a consistent way. And we've been able to show there's a gap there that needs closing. How we may close that gap? Well, this is very recently announced an NIHR-funded study for the London School of Hygiene and Tropical Medicine, the OpenSAFER team, into how long COVID affects the quality of life. And it's a study to work out what the long-term care implications are of having long COVID and what the health economic consequences of long COVID could be to the NHS. As I've said, we don't have that data in electronic health record data. So we've taken an approach where we're bringing together electronic health record data and personally collected data, so PHR data, using a smartphone application that TPP freely provide to be able to collect that data. So for patients who consent to be part of this study, who've been living with long COVID at some point, they can answer questions about their quality of life and validated questionnaires about the impact of long COVID on their daily lives. That data feeds down into a personally health record collected database, which will link to the OpenSAFELY EHR database inside that secure platform and enable the epidemiology team and the health economics team to do that analysis across personal health record data and EHR record data together. That's the first time that that's been able to be done at scale. And what we're hoping is that gives us a new route to be able to do important analyses. If we could go back at the start of the pandemic and be able to accurately collect people's occupations, for example, we've been able to do some really interesting, important analysis quickly into which frontline workers, for example, should be prioritised for vaccination or shielded the most. Lots more important work going on as the vaccination campaigns roll out. As I've mentioned, vaccination effectiveness studies, breakthrough infections in vaccinated people. And as we roll into the booster campaign and into childhood vaccinations, of course, we'll be able to do the analysis there and provide the reports to government as and when they're required quickly. So the platform continues to be very, very powerful and very useful in the pandemic. It's still set up under the COPI regulations for COVID. We're hopeful that the database may survive post-COVID, certainly support from the cities and juries to do that. But just as importantly, we're hoping that the principles around OpenSAFELY will have a legacy. So the idea around collaborative working, open analysis of EHR data, and building trusted research environments in situ will be something that can be taken up by other groups and used so that we can really unlock the power of EHR data in a safe and secure way. So thank you very much. I look forward to chatting with you all later and being at the Unconference, and hope everyone has a great day, and thanks to the Open Data Saves Lives team. Thank you.